Good afternoon, everybody. Mike Lagerquist here from Vine Faith in Action. Thank you for joining us today. Today we're going to be hearing a little bit about chronic pain and how to treat it, which is something that I personally have been dealing with now for the last year or so with some arthritis in my hip. So I can certainly understand the challenge that comes along with it. And all these people who are warning me, don't worry, Mike, when you get older, you're going to start feeling some chronic pain. They all, of course, were right. So we'll just deal with that as it happens.
Mm-hmm.
I'm going to introduce Christy Wilking. Christy is from Mayo Clinic Health Systems, and she will introduce Dr. Schumann.
Sure. Well, thanks everybody for being here today. My name is Christy Wilking. I work in community engagement, and so we typically do several presentations with Vine Faith in Action every year, usually in person in the community room, but thank you for joining us virtually today. This was a presentation that was supposed to happen back this spring, so we're glad that we're able to do the presentation today. So I would like to introduce Dr. Matthew Schumann, who works as a clinical psychologist with Mayo Clinic Health System, and he is going to take some time today to talk to you about chronic pain. So Dr. Schumann.
Thank you. Thank you. What we're going to be talking about today, an hour isn't going to be enough, but I'm going to try to share some perspectives. My experience, I'm a clinical psychologist, but much of my training is in managing chronic pain and in pain rehabilitation. I worked for 2 years in the Pain Rehabilitation Center in Rochester as a fellow, and I work currently with individuals from a cognitive behavioral perspective to help improve functioning in the context of difficulties with pain, often optimizing a lot of the different treatments and approaches that are recommended. And I think it could be helpful to start understanding from a definitions perspective of pain. So I'm going to see if I can advance these slides. If it works, let me know. Did the slides advance? Yep. Perfect. I saw a thumbs up. I'll take it as. So why are we even talking about pain? Well, chronic pain is a widespread problem. And as Mike, as you mentioned, later in life, it becomes an increasing problem. About 100 million Americans per year experience chronic pain. And the cost of such on the individual, on society, on the medical system is extremely high because the prevalence rates exceed that of heart disease, cancer, and diabetes combined. It's one of the most common conditions that bring individuals to see a healthcare provider. And looking at trends over the past 20 years or so, these costs are astronomical. And what's interesting too is that these approaches that I'll talk about today to help manage pain and how to treat it are often ones that are the balance of a lot of different things coming together at once. And so from that understanding, what makes pain complex and how to treat it complex is, this is a new definition that was released just a month ago, and a bunch of researchers and professionals got together to look at how do we define pain if we're going to research it, if we're going to work on it from a clinical perspective. And the definition that they've been working with and come up with was pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, if that isn't confusing enough, it doesn't provide different angles and lefts and rights and how to follow it. Simply said, pain is a complex experience influenced by a lot of different factors. And from a medical perspective, over the last 300 years or so, it was assumed that all pain is some combination or correlation with tissue damage. The assumption has been there's an underlying disease, malignancy, or injury, and that should match the amount of pain that someone has. And from that perspective, you search for the pathology or something, tissue damage, injury, malignancy, you name it, and the issues with the tissue. So you address the tissue, you reduce symptoms, and pain from that perspective serves as the safety alarm for the body. And all of our areas of our body have these safety alarms, except maybe our fingernails and our hair. And this works for what's called acute pain. And acute pain tends to be, as I mentioned, the issue is with the tissue. And there's different types of pain too. So if I haven't gotten confusing enough in my first 3 slides, most pain is processed from the periphery or the peripheral nervous system. And that's just a fancy way of saying everything except your spinal cord and your brain. And that's typically messaged from nerves, nociceptors, or what's called pain nerves or pain neurons, and the sensory cortex. So that those messages go up to two strips of our brain in the central nervous system called the sensory cortex. And I promise I won't stay too sciencey with us here, but it's important to understand this process because often individuals feel invalidated when describing their pain when providers don't necessarily find an answer for what's going on. And it's often influenced by the combination between these messages within outside the spinal cord and brain, the periphery, and inside the spinal cord and brain, the central nervous system. So the periphery, it's typical when there's an injury, there's some sort of activation, not even injury, any type of sensory experience. So if I touch my hand, for example, there's periphery nerves in my hand that sends a message to my spinal cord and then up to the sensory cortex to say, hey, something just happened in your hand. These muscles and these sensory neurons are found in nerves, muscles, tendons, and what's processed and looked at through the process of pain is the central nervous system is the determiner, the moderator of pain. The brain and the spinal cord determines the extent to which pain influences the individual or what's going on. And you can think about this, maybe you've gone through your day and noticed a bruise or a cut and thought, where did that come from? Or perhaps something that you hadn't noticed before, that you were busy, and then later you notice something hurt really bad, and you go, oh, I must have tweaked my knee or something like that. Now, in the moment that tissue was damaged or injured, there were messages being sent from that area that was damaged or injured. Now, what's going on is often mediated by what your brain and body is doing at any given time. That's influenced by things in the spinal cord and brain. So differentiating acute and chronic pain is important in terms of the treatment of pain. For acute pain, this acute pain is something, usually a symptom tells you that something's wrong and you need to do something different, right? So if I put my hand on a stove, I'm going to remove my hand to get rid of the thing that's causing me pain. With chronic pain, I like to say that chronic pain is a system within the body that shouldn't have happened. If you think about acute pain as an alarm system and a protection system within the body, chronic pain is an overreactive alarm system. It's kept on for some reason, and a lot of those reasons are unique to the individual that I'll talk about here in a little bit. And that's why often various pain treatments or chronic pain treatments might work for some, and other treatments work better for others. And that's also what leads to the frustrating and confusing aspects of managing and addressing difficulties with chronic pain. And as I mentioned here, it represents an overlearned neurological pathway. And often those pathways are hard to see. So if you go to the doctor, you can see degeneration of the spine. You can see the different types of injuries and illnesses. So you break your arm, you can see a broken arm. What's frustrating is often with chronic pain, for some reason that pain is stuck and is no longer a good indication of tissue damage or injury. And a lot of things can influence that. And I like to think of this too, is that tissue damage isn't always a good indicator of pain, because we can have two individuals here, and let's say the one on the left, his spine straight as an arrow, one that everyone would be jealous of. The one on the right has some degeneration, there's disc space narrowing. And if I asked you, which of these two people is more impacted by pain? If I go ask the physicians out here in the hallway, which one of these are more impacted by pain? They're going to go, well, that one. I'm going to assume the one with disc degeneration, bone spurs, and narrowing has more pain than the one's spine that is straight as an arrow. And what we know from a research perspective is that approximately 50% of the time, there are other factors that account for that pain level 0 to 10, not just tissue damage and injury. So frustrating enough to see that that individual with that spine straight as an arrow might be reporting high levels of pain that's influenced by other things, not just tissue damage. And often it's the circuitry within the body and the spinal cord in the brain that influence that, the overreactivity of those types of neurons and circuitry. And I like to think of this. This is a great study that looked at scans of spines. They had people come into the lab and they gave everybody an MRI and looked at their spines. And these were people who weren't reporting pain, but they wanted to look for two things. They wanted to look to see how many of these people actually have disc degeneration and how many people have bulging disc. Two scary words that show up in the context of difficulties with pain. And they had individuals from a variety of different age groups. First was 20-year-olds. And this is often eye-opening. So often you can think here, you're all on mute, but just think to yourself, how many people do you think in the age 20 have disc degeneration? They found about 37%, over a third of individuals have been found to have disc degeneration. If you just get a group of 20-year-olds, I should say, off the street, you scan their spines, you look at them, about a third would have signs of disc degeneration. At 50 years old, go ahead and make an estimate to yourself, 80%. And at 80-year-old, it doesn't stop. Often that's close to 100% of individuals at 80 years old have some sign of disc degeneration. Now, seeing this, and the words disc degeneration often bring up a lot of alarm, and it's a scary term. And this shows that above the age of 50, you're more likely than not to have disc degeneration if you present for pain or if you don't, even if you don't have pain. Bulging disc, another scary word. At about 20 years old, about 30%, 3 out of 10, will have some sign of bulging disc on a scan. At 50 years old, it's up to 60%. At 80 years old, 84%. So another way to look at this is if you look at age 50, it's more likely than not that individuals with chronic pain or without chronic pain have some sign of disc degeneration or bulging disc. And that says that tissue damage can be misleading with the amount of pain that's there. Another way to phrase this is if you live on Earth long enough and experience the effects of gravity for longer than 50 years, you're more likely to have some of these signs. And so often that change of what one approaches with regard to acute and chronic pain. The assumption for acute pain is you rest, you heal, you get better. With chronic pain, for some reason or another, you rest, you heal, you wait to heal, you check, and pain's still there. And often that's differences between how the signals are processed within the body here, as you see with acute pain. Often those messages travel to the spinal cord amplifies that message, and the message is sent to all the different areas of our brain, and then from any given point in time, we make a decision about the threat of that pain. With chronic pain, there's more activity, more pathways within the brain, and the spinal cord doesn't necessarily reduce that message. So typically with pain, if I break my arm, for example, after about 0 to 6 months, that pain should resolve. With chronic pain, it's not just prolonged acute pain. What we know is that for some reason, there's a variety of factors in the spinal cord and the brain and in our environments, the way that we think about our pain, that influence how that volume knob can be stuck. And often the explanation that's assumed to be why that might occur is what's called central sensitization. And boiled down as simple as I can, is as signals travel through the nervous system, whether that's sensation signals or pain, they may turn on or activate certain circuits within our bodies. And the brain uses these signals to warn us that something's going on. And with central sensitization, pain can often result from the brain's attempt to warn you from danger. And these circuits get turned on, and it's easier for them to turn on and on again. The body and brain gets primed for pain, if you will. It becomes too good at it. Because I like to say that pain is good because it protects. Chronic pain is not good because it loses its function. Its purpose of protection has become it has overextended its welcome, if you will. And repeated warning signals can cause those changes in the brain, changes in the spinal cord, and the brain may start to become more, it might start to process more areas and dedicate more space, if you will, to those danger signals in the brain. And in time, even one danger signal may activate many regions in the brain, triggering that difficulties with pain. Like I said, everything here can be perceived, or every signal that shows up can be perceived as a threat. So what's called allodynia. So that process of allodynia is things that often can be like a light touch resulting in significant pain, or hyperalgesia. So things that the process of pain tends to be heightened and shows up even when it's not necessarily called for. So as I mentioned, brain is overlearning, and it can be that process of the brain becoming overly sensitive to those types of signals. And it's a normative process for us to learn from situations, and we develop different types of learning in different situations as well. It's when the brain becomes too sensitive to those types of signals, or overreactive to those types of signals and responds to greater threat, that it becomes more problematic. And the emphasis here is that individuals with chronic pain are not faking. We see this process. We can see activation from pain and different activation for those that experience chronic pain. There's more widespread. And so often the message that individuals that I work with here, they go, why am I meeting with a psychologist? Are you saying my pain is in my head? And I say, pain's not in your head, but it is in your brain. The connotation that the pain that one experiences is real. They're not faking it. And we can see it with activation within the brain, but that's hard to measure. And so often we think about coping and how do you cope with acute versus chronic pain? When you have acute pain, you might rest, you withdraw from activities, you stop using that body part, you take medications, you eat less or you might eat more. And from that perspective, you rest, you heal, you get better. With chronic pain, you might change your diet, and changing diet over long periods of time might result in irregular food intake, weight loss or gain. You might start to withdraw from activities, leading to more anxiety, less social connections, lower independence. You stop using the part that's in pain, which can lead to, over time, longer than that 6 months, deconditioning and muscles becoming more tight or just weakening over time, which can increase anxiety or concern that the next time I go to use that area or my body part, I'll be in pain. And that reactivity to pain can actually increase and lead to decreased tolerance of activity and physical endurance. And often medications start to lose their efficacy over time and come with greater side effects as one starts to take more medications to address difficulties with pain. And then with regard to rest, often pain disrupts sleep cycles, which can contribute to more pain, can lead to fatigue. A lot of nasty side effects that come with addressing chronic pain from an acute perspective, if that makes sense. If we use acute approaches to treat chronic pain, this is often what shows up. And so we've got to take a different approach because acute pain tends to be more biological. Chronic pain is often influenced by a combination of these 3 different factors here. Biological factors in terms of the reactivity and sensitivity within the body, different tissues, muscle conditioning, those types of things are biological factors. Things like stress, difficulties with sleep, long-standing anxiety and depression, a tendency to be a perfectionist are psychological factors known to predict the onset of chronic pain and longer difficulties with chronic pain, especially how one thinks about their pain, what's called catastrophizing or pain catastrophizing, thinking the worst about their symptoms or limiting activity because of symptoms can influence the volume knob on pain and tends to be a big predictor for disability associated with chronic pain. And then social factors, things like environments, stressful environments, how one is responded to when they experience pain can often influence pain. And I'll talk about that here in a bit. So this is to say that chronic pain, it's an unreliable alarm system, no longer going off when it should, and often results in frustration as many unsuccessful treatment trials occur. And there's not always a clear cause, which is increasingly frustrating. And then we think, well, what do we do? How do we treat this? If it isn't confusing, and if I haven't come from a lot of different angles, how do we treat it is a very complex statement. And that process of how do we treat it starts with the brain and the spinal cord and the central nervous system. Because if the pain system is working as it should look like this. Message are sent to the spinal cord and the brain. The brain goes, hey, something's going on in that area. It sends a signal of pain. It creates pain in that area or sends the message of pain. And once the body has taken measures to take care of itself, to rest, to heal, the message turns off. What often happens with central sensitization or chronic pain is that message to turn off loses its strength. And it might not even be there at some point. The ability to turn off the pain signal loses its strength. And so we've got to start to look at different approaches to soothe the central nervous system, as well as paying attention and mindful to the areas affected by pain. And it's a process of rewiring the brain and pick it so that the brain isn't picking up danger signals and letting those pathways heal. So I think of, with regard to circuitry, kind of like this picture here in the woods, is when chronic pain occurs, and it becomes problematic over a long period of time, and it impacts the individual in a lot of different ways. the pain circuitry starts to turn into almost, rather than a well-trodden path here, but almost like a superhighway. So the goal is to start to rewire and restructure how the brain and body is responding to pain and changing the relationship to how the brain does that. And it's often taking a different approach and creating new pathways, because the brain and spinal cord is plastic and can create new connections. And in doing so, often the question is, well, is there a medication for this? And there's some that might help somewhat and often can support the ongoing treatment and management of chronic pain. Things like tricyclic antidepressants or SNRIs and antidepressants, and duloxetine and venlafaxine, or pregabalin, gabapentin. Maybe you've heard of Neurontin or Lyrica. Those types of medications can be helpful. What tends to be less helpful with chronic pain, and we tend to see this at doses that have lasted longer than about 30 days, is opioids can actually increase sensitivity to pain. And overproduction of pain within the body often leads to further functional declines. And that's often why those types of medications are either recommended as a bridge toward functioning and maintaining functioning, as opposed to relying on medications alone to manage pain. Because if that had been the case, addressing pain from one of those 3 bubbles that I showed you earlier, if we address it from one area, there's still 2 other bubbles that are at play with regard to the pain experience. And what often happens is the sensitivity and increase in receptors for opioids within the body tends to result in an increased reliance on opioids to manage pain from an internal perspective. And so the best practices encompass a lot of different things at once. I like to think of managing chronic pain as a lot like managing any chronic condition that one experiences, like diabetes, for example. It requires a lot of things working together at the same time from a lot of different angles. One is soothing the central nervous system, change pain thoughts, changing pain behaviors, asking for support and support for health change, activity and stretching, regulating sleep, healthy whole foods. I'll talk about each of these in turn, but I want to emphasize, and a lot of the patients that I work with, I often refer to VINE, because a lot of these different approaches that come together are often provided in community settings, and VINE actually provides a lot of these that support health behavior change and management of pain. So I'll give good kudos to VINE as I see this, because those are important in terms of long-term management, especially as the number of individuals experiencing chronic pain isn't decreasing. And so first recommendations are attempting to engage in gentle stretching every day. And the recommendation is finding, again, this is often something that I recommend working with primary care providers or physical therapy, but to identify a stretching routine that would be helpful to make sure that the areas, when bodies stop moving, they become tighter. And so it can be more painful to move. So often the recommendation is about 10 to 15 minutes a day, moving every about 25 to 30 minutes. So we're just about at the 25 to 30 minute mark here. I would often recommend taking a standing stretch break, or I like to say a gentle movement break, to ensure that those muscles aren't tightening up and making it harder to move. Again, using correct posture and breathing, and things like gentle yoga and Tai Chi can support some of this. And often individuals assume Tai Chi or yoga must be done standing. I often encourage any movement while sitting is also just as important. And then addressing stress, because if you look at this, stress influences physical, emotional, cognitive, and behavioral responses. And chronic pain is a chronic stressor on the body. And it keeps stress levels high within the body and influences these different types of symptoms that show up. The patients that I tend to work with tend to say that this is kind of like a bingo card, and they play blackout, because they can go check, yep, this is what I experience with ongoing difficulties with pain, because it influenced the body and person from a variety of different angles. So the first important aspect is if we can soothe the central nervous system, because what happens is when pain persists and continues, it keeps individuals in an overwhelmed state, higher than they typically would be sitting. And often individuals with chronic pain report that things that used to not bother them now, or that they're more irritable. And so the goal then is to find a balance to the type of response, because when stress is high and stays high, the balancing response of relaxation often doesn't kick in or loses its strength and keeps the body activated, tense. It might be increased heart rate, increased blood pressure, breathing rate increases. And so the goal is to show the body that that balance is there, and kicking in a relaxation response, or I call it kicking in, but utilizing strategies to balance a stress response to bring the body back down below that overwhelmed state and more calm, a more relaxed state. And in doing so, there's a lot of, and this is what's called the parasympathetic nervous system. And that's just a fancy word of saying our body's relaxation response. And that relaxation response can be kicked in by slow diaphragmatic breathing. And that's taking just maybe 5 minutes in your day and slow breathing from your belly. And if you think about slow breathing from your belly, when we're anxious, when we're in pain, often we're breathing up here, we're tight, we're more likely to overbreathe. If we slow things down, it's often the one system within our body, within the stress system of the body, that we have most control over. Other strategies like biofeedback can actually see that take place. So biofeedback is a strategy in which people either hook up their muscle tension or hook up muscles to electrodes, and you can see the level of tension on a computer screen. There's a program that usually runs and sees how much tension is in that area. Or you can hook up a band around your waist and watch your breathing rate over the course of a minute. And the goal with that is, if you can see that activity and tension, you can decrease it through the use of relaxation strategies. Things like passive or muscle relaxation or self-management strategies that are helpful. Also visualization, meditation, yoga, tai chi. And the recommended dose is about 30 minutes a day, can help reset and soothe the nervous system over time. And bring, because what's thought is pain and stress set the thermostat for stress within the body. So if we can implement relaxation strategies, that thermostat can get reset below that overwhelmed state. And what we know too is that individuals with chronic pain tend to breathe more rapidly than non-chronic pain patients. So that's often a result in increased muscle activity, the chemistry in the blood, and the nervous system response. And if we can slow that down, it changes how the body responds to those types of symptoms and decreases the alarm that goes on within the spinal cord and the brain, because pain thoughts also alarm the brain. And I like to say, if you think about and you anticipate pain, your brain's already primed and ready to look for the danger. And so aspects of addressing pain thoughts might be finding thoughts that tend to amplify things like, I can't stand it, or it's killing me, or I can't go on like this. Or it might be, I can't do this at all. Those types of limiting thoughts can increase that volume knob on pain. And the goal here is to not deny the experience with pain, but to take out the alarm to it. So I like to say, suck out the emotion from that high intensity, high stress associated with pain. So it's not sunshine, rainbows, unicorns, everything's perfect, I'm not in pain. It's thinking thoughts like, I don't like it, but I've dealt with worse, or it's bothering me today, so I'll need to adjust my day. That more flexible form of thinking often lends itself to functioning. And if I haven't said it up to this point, that the focus of chronic pain management, if we focus on that volume knob for pain, we might not be successful given the strategies that have been utilized before. So the focus on function tends to improve quality of life. It tends to decrease depressive symptoms. And in doing so, without even focusing on pain explicitly, pain tends to decrease. And if we can decrease suffering, pain tends to decrease as well. And it's cool to see that these types of strategies addressing pain thoughts are shown to change the brain, because the typical response to pain is messages come to the middle of our brain, a relay center called the thalamus. And it connects when pain is high, we see heightened activity in the amygdala, which is our emotional centers. Often fear is often strong response and strong activity caused by the amygdala. And also the hippocampus, memory centers get involved, because often memories form when the threat should be there. And then it goes to our thought centers, where the high level of threat is there related to pain. That threat level is increased. With the different types of strategies to address pain thoughts, the wiring tends to activate within the frontal cortex to slow and soothe the response to pain, rather than viewing hurt equals harm. To hurt might lead to some discomfort, but I can manage it. That type of response changes how the brain responds. The heightened fear and heightened emotional alarm is overridden. And that tends to be most effective. So what we see is if we can address difficulties with pain from a lot of different angles, we can soothe the central nervous system by addressing thoughts, addressing emotions, and addressing behaviors. And that's what cognitive behavioral therapy, or the approach that I utilize, is addressing the connection between those three things while supporting physical conditioning of the body, tends to result in better outcomes for individuals with chronic pain above and beyond just one approach alone. Also addressing different types of pain behaviors, because what often occurs over time is these types of behaviors tend to be ones that, from an acute perspective, make sense. When we're in pain, we grab an area, we guard, we might cry, we might talk about pain, we might rub an area. If from an acute perspective, that's helpful. With chronic pain, these types of behaviors activate and alarm the brain. So if it becomes problematic, is looking at ways to decrease these types of behaviors when experiencing pain, and from a behavioral perspective can also change how the brain and body responds to pain and symptoms. And then from a social perspective, is often talking about pain alarms the brain. It keeps that signal activated and ready. So asking about how family might support you, not asking about pain, offering distracting opportunities and activities, encouraging praise for healthy behaviors, complimenting efforts, and reminding yourself of prior successes and having the environment support that tends to be most effective, because there's a balance between pain and responses. There are responses that are more punitive, like, oh, you know what, just push through it, just ignore it, you'll be fine, that we get from our environment, which often leads to feeling invalidated. It leads to one to feel like they can't express how they feel, and they might isolate more. And when individuals isolate more or do less, mood worsens, and as the connections between the brain have shown, tends to turn up the volume knob on pain. You might get another response too of, oh, I've got this. Don't worry about this. I'll take care of this. I'll take care of that. Take care of this, and take more and more. And that type of response often can be unhelpful too, because one, the individual might think, well, hey, I got this, no problem. Don't worry about me. I don't want to talk about my pain. And so they might, again, not express how they feel, or they might lower their confidence to engage in that activity because others have been stepping in despite their the difficulties that they've had, which can lower one's ability to engage in that activity and decrease tolerance of that activity when they don't do it over time, and then pain tends to worsen. So finding a balance between that, not from the overly punitive and getting punished for your pain, but also from your environment, but also not one that's overly and overbearing with regard to management of those types of symptoms, is something that's often important. And then one of the hardest things to describe is, well, if I'm in pain, why should I increase my activity? And what's often encouraged when pain has lasted longer than that expected healing time, when it's chronic pain, engaging in physical activity in a systematic, gradual approach, and that includes stretching, strengthening, and aerobic conditioning at a pace that's recommended for you, for the individual, it starts to reverse some of that deconditioning. It wakes up some muscles that haven't been activated in a while, and supports the musculature and skeletal system that's there. But also reverses some of those danger signals within the body as the brain starts to say, well, healthy people exercise, so this must be healthy. I'm not causing further damage. I'm doing this to be healthy. And that process of increasing activity despite pain is a balance, because you want to increase systematically, but you don't want to go too far, because overdoing it can also result in a pain flare, which is frustrating, which might lead to a pattern of underdoing and inactivity. And that's where moderation of activity is one of the most important skills that one will learn to manage chronic pain in the long term, because it's a balance between waking up the muscle groups, and there might be some discomfort with that, but also not falling into a pain flare. And often an overdoing shows up when, on a good day, you try to catch up on all the activities that you hadn't been doing. Or, I feel good, so I'm just going to do this because, hey, I'm going to pay for it later. That approach, while it makes sense in the time, can actually increase the probability of a pain flare and lead to an unhelpful cycle of frustration and prolong the process. So some tips for moderation to help break up that cycle are things like developing a scheduled routine of normal activities. And I like to say this as a backup, as something that when things tend to go off course, having a schedule can be helpful to reflect on. and alternating between light and heavy activities, not that process of go, go, go. It might be I increase an activity for a little bit and then I take a break. And I might not return to that day, but I might also take a break and return to it later, or return to another activity that's lighter, less physically demanding. And then spreading activities out throughout the week, something with that might include frequent duration. You might break up into smaller steps and taking frequent breaks and using modifications as possible, as reasonable also. So you might physically change how you approach the activity if you've typically done something a certain way. You know, I think about this as if you typically do the dishes a certain way and results in hunching over and you've got a lot of back pain from doing so, you might utilize something that either changes the posture at which you're doing that or take breaks to do it in different ways. So it might be, you know, I do this for 5 minutes, even though I could do the dishes in 15, no problem. I would do it for 5 minutes, I take a break, and then I come back to it for another 5 minutes, and then I take a break. Or it might be I do 5 minutes sitting at the dishes or something to help support that activity, and then I stand for 5 minutes. Alternating that behavior and alternating that activity is most important for moderation as well. So here's an example of a routine that someone might set up for themselves in a week. So that might be something throughout the day. They built in things like walking and stretching earlier in the morning. You might include a productive activity, whatever that is to you. That could be chores around the home. That might be a phone call. It might be a social activity. It could be a recreational activity. It might be things like building in the things that can help calm the nervous system, like meditation in that next chunk, and alternating between productive activities and recreation activities. It might be social activities. And at night, utilizing some of those relaxation techniques. So good different types of phone apps can be helpful to utilize with regard to relaxation. Things like Calm app or Breathe to Relax, or a couple apps that have been helpful and that I've heard have been helpful. Headspace is another one of those. Some of those cost money though, which is can be a prohibitive barrier to that. So often looking up different types of relaxation strategies on YouTube is often what I recommend as well. And then that gradual approach to activity. So this can help with moderation as well. So if you have a goal for activity of how you want to do it or how frequent you want to do that activity, let's say you want to take a brisk walk. You might estimate the amount of time that you could do that no problem. And you say, okay, well, brisk walk, no problem, easy peasy in 5 minutes. That doesn't bother me. But I know if I do that for 15 minutes, pain's going to raise to about an 8 out of 10, and it's going to be problematic and often lead to the next pain flare. But I want to get to 30 minutes of that activity. The recommendation for gradual approach for activity might be you start with the first week of just a little bit above that no danger zone. So something that might be 8 minutes. On a good day or bad day, you keep yourself to that amount. And then you find, again, build in a break time with whatever that might be. And that might just be per day. And then gradually over the next week, you might increase that by 12. The emphasis here is you start at much lower than the danger zone. You keep yourself away from the overactivity or overdoing level as you gradually get used to that activity. And along the way, you might be frustrated with that because you go, gosh, I should be able to do that right now. That process of building up is just like you would with physical therapy or going to the gym. No one goes to the gym and maxes out their weights every time. They gradually build up over time to get used to that activity. Same things apply with daily activities. So it might be over time you're getting to that 15-minute mark at about week 3. And hopefully as you get used to that activity and building in activity over time, and again, all of these are based on recommendations from providers and based on what would be a good fit or interest for you, is that over time, at about a month and a half, you're at that goal mark with consistency. And then improving sleep is also important. One of the biggest issues that individuals that I see is it's not just pain, it's I can't sleep either. And not being able to sleep contributes to worse pain and fatigue the next day. So utilizing good sleep hygiene techniques like establishing a regular bedtime routine, no screens, making sure that you're in bed only for sleep. And I say that, and this is going to be my brief talk on sleep rather than pain, is that we get used to associating discomfort with our beds, especially if we toss and turn. So if you notice that you've been awake after about 20 minutes, I even say about 15 minutes, or even if you have the thought, I can't sleep, get out of bed. do something boring, and then return to that. And something boring might be you look at a newspaper for that day, or you might find something that is not mentally engaging, whatever that is to you. And then ensuring that you're napping less than 30 minutes, because napping disrupts sleep quality as well at night. And then not trying to sleep, as I mentioned, and practice some of the relaxation techniques that you might utilize over the course of the day, and then using positive self-talk. That's easier said than done when sleep is difficult, but often it can be helpful to improve sleep quality, and using some of the relaxation CDs or apps that I talked about. And nutrition is important as well, and often the recommendations, at least from the Mayo Clinic diet, are things like decreasing inflammatory foods. So things like processed foods and sugary snacks are often associated with inflammation within the body. And there's connections between inflammation and low mood, or pain and low mood. So focusing on fruits and veggies and whole grains, nuts, legumes, vegetable oils, minimal dairy, red meats, processed foods, and white flours tend to be most helpful. And if you look up the Mediterranean diet, that tends to be the most easiest diet to follow, to build in the different types of menus and food options to help with that. Other approaches that can be helpful from a non-pharmacological approaches are things like heat and cold, and different types of manual therapies, massage, encouraging weight loss. And I've heard from my physical therapy colleagues that 1 pound of weight loss takes 10 pounds off the joints. I might be butchering that, but he said something along those lines that was eye-opening to me. And utilizing those types of strategies, as we talked before, to support health behavior change. And that might include things like using a walker, using a cane to ensure that mobility and technique is okay, or recommended from providers. So things like assisted devices. Things like TENS unit can also be helpful in terms of counter stimulation within the spinal cord and brain, and within the body and the periphery. That tends to be how the TENS unit works. And then acupuncture is another non-pharmacological treatment approach. So this is to sum up everything that I've said, and I've spun through this very quickly. And so if you have any questions, I'm happy to answer this with our remaining time. But a good pain care plan means addressing pain from a lot of different angles. So it might include things like building in active relaxation strategies, daily physical activity, yoga, stretching, Tai Chi, watching the words that you say about pain, because that alarms the brain and the thought centers associated with pain, which keeps the threat level high associated with pain symptoms. Decreasing pain behaviors, and scheduling and pacing activity and moderation is often the most important skill and most difficult skill at that. Good nutrition, good sleep habits, and having a social environment that supports health change, and encouraging the social environment to support health change can be helpful as well. And so I often use this framework of incorporating a good pain care plan, of getting each one of those different strategies, what that strategy might be, the specific thing, when you might do that. So building a time of day, maybe a time of the week, and then where you might do that as well. Is that something I do at home? Is that something I do at Vine? Is that something that I might do in other areas of the community or with my other providers? That's all I have in terms of the information regarding chronic pain and ways to manage it. It's complex and requires a lot of different approaches to address that, and it's unique to the individual. If you have any questions, feel free to reach out to me, to reach out to your primary care providers, and then identifying good ways, good comprehensive ways to address difficulties with pain that is stuck for some reason or another.
All right, if anybody has any questions, feel free to unmute yourself first, and then to ask the questions, Dr. Schumann. Ken, did you have anything that came to mind for you? I don't know if you're speaking, but we can't hear you.
There, now you hear me?
There you go, yep.
Okay. Yeah, I do. What about alternative medicines like ginseng, cinnamon, all that kind of stuff? I didn't think of turmeric as one example. Have you found any success with those?
That depends. So I think that speaking with your primary care provider and see what they have to say about the medications or the supplements rather, if they find that helpful for them. Some people say that some supplements tend to be helpful. Others say that not so much. So it's about finding a good balance and what would work and what's reasonable and different types of recommendations from a medical perspective as well.
I found out that doctors actually don't have that much, I guess, education on minerals and supplements, and do the pharmacological people.
Yeah. So often it's, and that might be too something that I've had individuals work with pharmacy here to identify what's a good medication options with regard to pain. Because what we know is that non-pharmacological approaches for pain and lower risk factors associated with medications tend to be helpful in the long run for pain management. So the least amount of medications with the least amount of side effects with the tend to be most effective and can be effective, I should say, if that approach is improving functioning.
I have found, well, I have a lot of arthritis through my body, but I have found that doing stretching helps a lot.
Yeah, stretching is important with regard to arthritis pain because it supports the muscles around the areas that are often weaker. And the recommendations follow a lot of the things that I had mentioned as well, that a comprehensive approach to maintaining, it's about finding balance is what I mean to say, is if you can still do the things that you enjoy, often suffering will be lower. And if we can decrease suffering while increasing activities that you enjoy and doing them maybe a little different way than you had before, that tends to be most effective. And often that includes physical aspects, stress aspects, social aspects. That's, yeah, good questions.
I do know for myself that I got prescribed some stretching to do, and I admit I have not been doing that as diligently as I should because I discovered naproxen, and naproxen helps me get through. I do like to get out and walk, and the activity primarily is what really keeps me going, because I know if I don't get out for a few days, I feel that in my system.
Yeah, and I think that emphasis on function. So the key there is maintaining that activity, and often stretching can help along the way with a lot of those different things.
Have you had patients that say, well, Tylenol doesn't work, but the product does? So everybody's different again?
Everyone is different. I've had patients say that they've tried everything and nothing works. I've had patients say that they've tried one medication and it's the best thing ever, and another patient say another medication doesn't work, or they can't take them due to different types of medical conditions. Concerns with their kidneys.
I do know that Percocet works because I pass out.
So often, those types of opioid medications can be helpful in the short run. In the long run, they tend to not necessarily result in better outcome.
Was GRADUAL kind of a low opioid?
Tylenol?
No, tramadol.
Tramadol, yep. So that's labeled as an opioid, and it tends to be the lower risk of those. But all those types of medications carry their own risks and are controlled substances. And especially as one gets older and experienced, if you will, combining a lot of those medications can be increasingly dangerous, especially combining opioids and benzodiazepines. So I always say, speak with your providers about the different types of medication recommendations that you might have, but often addressing pain from purely a medication perspective, a chronic pain, I'll say, addressing chronic pain from a purely medication perspective can be limited or provide short-term or modest relief.
All right. Anybody else have any questions, Dr. Schumann?
I have a quick question for you if you want to answer it. I know you talked about anxiety around anticipating pain, and I know I've experienced this myself with chronic pain. in my mind, I think it's going to hurt, so I step differently on my foot, and I find myself with more pain because I'm anticipating that that's going to hurt. Do you have any strategies around how to overcome some of that?
So that's a fantastic question. One is changing how you, with regard to the pain behaviors, going back to that, is that engaging in a different, leaning a certain way or guarding an area can put strain on other areas of the body and create new difficulties with pain. So part of that might be anticipating pain and can cause a lot of stress. So part of that might be, prior to engaging in the activity, utilize some relaxation techniques, challenge some of those thoughts of, we like to think that we're great fortune tellers and can see into the future perfectly. But keep in mind, as you're engaging in activities, the recommendations that you have with regard to mechanics, the recommendations to take breaks, to moderate that activity and modify it in a different way, and then challenge some of those thoughts of that we can predict the future. Because often we don't necessarily know the outcome. We're based on probability, but the outcome might be different if we do things a different way. And that can help with some of that anxiety or concern, or it might mean just doing that activity a little different way so it's less stressful and putting less stress on the body, if that makes sense.
All right.
And often that's changing how one views that activity changes with experience. So by first challenging that and then engaging in that activity, you might see that, hey, that wasn't so bad. And then reflecting afterward and go, hey, that wasn't so bad. That wasn't so bad. Then it builds the next time that you go to do that activity and go, oh, remember that time that I did that and I thought I was going to be in a lot of pain and it wasn't as bad as I thought it was. And so that experience also, as I like to say, behavior changes biology too. It starts to rewire and it makes it easier to see the other perspectives. Thank you so much for taking the time to allow me to present. I think a lot of what Vine offers supports a lot of what I just went through and described. So utilizing I know that the yoga, the Tai Chi, the relaxation techniques, the being active and being involved, the pool therapy can be often helpful for those that find it difficult to engage in physical therapy on land or the mechanics associated with that. It could be a good bridge before one engages in physical therapy on land, is building up that physical activity in water as well.
Okay, yeah, thank you for that, because it's a good lead into, we do have, activities that are available now. We've got the fitness center, walking track, and pool are open. You do need to register for those. There are certain times of the day that we have them, but there's usually about 5 or 6 different sessions to give us time to go in and clean afterwards. And also we do have exercise classes that are available by going to vinevolunteers.com, our website, and going to virtual Vine, because we do some on a variety of formats. We do some on Facebook, we do some on Zoom, and in almost all cases, we do have recordings of those available. So if you can't make it to the class when it's in session, you can go back there on your schedule and check it out. Might be good to check with your primary physician if this is something that's new to you, just to make sure that it's something that you are eligible to be trying to do. But we have been trying to reach out to folks to make sure that that we, Move It Mankato, I think, is the program that they've been doing throughout town. So many locations for that. So thank you very much, Christy, Dr. Schumann,
Yes, thank you.
and everybody who's on today. If you have any thoughts on future presentation topics, please let us know, because Christy and I work together very closely on trying to find those topics. And if you can let us know, that makes it that much easier for us. All right, well, thank you, everybody. Have a great day. And thank you, Mayo Clinic Health Systems, for your presentation today.
Thank you so much.
Bye.
Bye.